Welcome everyone, and today we're going to discuss causality, the associations between the exposure and the outcome, and is there any particular relationship between exposure and outcome. What we call it causality. Is the exposure causing the outcome, which is the disease? So we're going to learn about the causality, types of the causality, and we're going to give examples. Causality in history, before, especially when it comes to the infectious diseases, right? There is many theories to assess the exposure and outcome. Some of them was just a fake relationship. Is there is no causality. It's not related. The exposure is not related at all with the outcome, and that theories started to develop as it goes. Okay, for example, looking to the infectious diseases as before, how they thought it just environment. For example, somebody have a plague, right, or have any particular infectious diseases or malaria or anything. They thought at the beginning, oh, this can be an environment, is just a place. If you go to that place, you're gonna get sick, right? But it's not about the place. Even they thought about what we call it the miasma, right? It's just bad air, mal air, and that word malaria comes from the mal air, which is the bad air, right? Thinking about it just about the air. For that reason, the people at the time, they used to carry flowers and smells of flowers when they meet each other. So it's just about the air. If I'm smelling the flower, that means I have a very nice air, right? So I'm protected. Is there any relation between that mal air or smelling flower can protect me to having the disease, yes or no? Then some theories about the spontaneous generation. Spontaneous generation, actually, that the living things comes from non-living things. Living things comes from non-living things. That they thought about, for example, look at the roasted meat, a roasted meat, right? And it has worm. So they thought, oh, the worm come from, which is the living things, the worm, the living things comes from non-living things, which is the rusted meat. Meat become dead, it's not alive anymore, right? So it's dead. So how the worm comes from the meat? They say, oh, this is a spontaneous generation, that the living things come from non-living things. However, this have been approved, it's wrong. And it was an experiment. They put a piece of meat, a roasted piece of meat, in a jar, which is exposed to the air. Other one, a roasted meat, which is covered by a gauze. And what's happened? They found the one it's exposed to the air is having the worm. Why? Because the flies, it go inside, laying the egg turns to the worm. But in the second case is what? They found that gauze preventing the flies to go inside, so it's not laying egg, so there's no worm. So this is a wrong concept about the spontaneous generations. Then come later, oh, do you know what? It's about germs, that we talking about. Oh, now in 1670 and up, starting developing the first microscope, and they can see the germs, right? And they can, oh, there is a bacteria, right? There is parasites. So there is a cause here. So it's very important to develop as a researcher, and this is what we want to learn here and equip you with that mentality, which is what I just want to make sure what I'm saying, the relationship between exposure and the outcome, it's causality, the exposure causing the outcome of the disease. For that, we classify the causality to two main types. Deterministics. What's deterministics? That means it's necessarily insufficient cause. Both. When you think about necessarily, that means the factor you want to evaluate or the exposure is required for the occurrence of the outcome. So mean if it's necessary, the outcome cannot happen or occur without the exposure. It can't happen without exposure. Okay, so if somebody have a problem with a lead poisoning symptoms, oh, he has symptoms, okay, that particular symptom for the lead, this is necessarily that particular patient have been exposed to the lead, nothing else. Okay, it's necessarily to give these symptoms to be exposure to the lead. Okay, sufficient, it means the cause is sufficient by itself to produce the effect. The cause is sufficient to cause the disease. It's not required. It's not required, but by itself, it can cause the disease. By itself, it can cause the disease. It can happen with something else. Yes, it can happen for something else, but that cause itself is enough to cause the disease. Okay, but the disease can happen from other reasons. Okay, like what? Smoking and lung cancer. Okay, smoking is sufficient to cause lung cancer itself, smoking causing lung cancer, but there is other determinant or factor may cause lung cancer. For that reason, we talk about how people they have lung cancer and they are not a smoker. But I know smoking will cause lung cancer, sufficient to cause it. But is this necessarily? So that means I cannot have a lung cancer without smoking? No, it's not necessarily. It's sufficient. Is that clear about this terminology? About, I give you an examples to make sure you get the concepts behind that. Is that clear?
Yes,
okay.
Professor.
Yes, Professor.
Great. Then we comes about probabilistics, which is here it's the probability, stochastics. Okay, I will discuss it, but let me finalize here the deterministic causality. Look at this diagram. I tell you about deterministic causality, which is necessarily right and sufficient, right? It can be necessarily insufficient, which is the highest relationship, or just sufficient, but not necessarily. About the lung cancer, here about the lead, here about the lung cancer, or necessarily but not sufficient. Okay, or necessarily, or is not neither necessarily insufficient. So here basically the deterministic causality is not achieved, at all. How the strength 1, 2, 3, sorry, 1, 2, 3, 4, the strongest one. Here necessarily not sufficient, still strong. Okay, 3, third degree. Then, neither. Somebody having raising a question here. What's the question? Look like by an accident. Okay. When you talk about probabilistic causality, okay, I'm talking about here about if the cause associated with the outcome. I'm gonna say it's most probably yes. Probability, right? That means if you get exposed to something, it's most probably you're gonna get the outcome. Like what? Radiation exposure as and having cancer as a carcinogenic source. The radiation as carcinogenic that causing a cancer. Okay, so this is to tell you about what type of causality that you may have. Very important when you think about the causality, okay? In any research, you like to look at that relationship. Is that causal, yes or no? So at the beginning, you start your research question, is there any relation between so and so, between the exposure and the outcome? What's the hypothesis? And I'm going to talk about the hypothesis. Is X and Y related? Usually when you put hypothesis, you guys going to say, they are not related. This is your assumption. The zero assumptions. So, hey, the lung cancer and smoking and lung cancer, are they related? I'm going to say my hypothesis, not related. And then you try to approve that relationship, and once you reject the hypothesis, you reject it. When you reject it, this is mean there's a relationship, because you approve, you can reject it. So if you can reject, there is no relationship, that means there is a relationship. And I will talk about this more further in the next slides. So you have the hypothesis, you have the variables, independent, as we learn, independent variables and dependent variables, right? I want to study, look at this, smoking, hypertension, diabetes, okay, gender, age, all these independent variables with myocardial infarction, with heart attack. I want to highlight this particularly diabetes as main, diabetes with myocardial infarction. But I have another independent variables that I want to control for. When you study, very important, and we're going to come to it. When you study that model, what I have just mentioned, diabetes, hypertension, age, gender, all those with particular outcomes like heart attack or myocardial infarction, I want to study one of them with the myocardial infarction. Diabetes was myocardial infarction, and they have to control for the rest. Control for the rest. Okay, that control, I can do it during the study design when I have two groups. I get all the people here, male, how many one male, how many one female. In this group, exactly the same, right? Age-wise, the same. All of them having hypertension or not, the same. So I'm having two groups, I'm trying to match these, control for the rest. I accept the diabetes. Group is diabetic and group non-diabetic. Then I run the analysis, right? If I cannot match what I do, if I can't match what I do, that's fine, keep it. But during the analysis, I will do the control. I will control. I put in the analytic model the hypertension, age, gender as a confounding factor or controlling factor that I will control during the analysis. So either way, you match when you study design, or you control this during the analysis. And most of the research about what controlling this in the analytic, as it's more easier than to find match this at the beginning, especially the retrospective cohort studies or retrospective that already have the data, right? When you do that match, when you do clinical trial experiment, now you can match, right? So you have these variables, okay? You have to do operationalizations to measure, as we're going to describe how we do that and giving example. Then you look at the study, you reject or fail to reject. If I say there is no relation between smoking and lung cancer, this is my hypothesis, there is no relation. If I reject this, there is no relationship. I didn't agree, right? You reject, you say you reject. If you reject, that means there is a relationship between them. If I fail to reject, that means there is no relation. The statement that I gave it at the beginning, my statement was negative, no relation. My statement, hypothesis, zero hypothesis, no relation. If I reject no relation, this means there is a significant relation. If I fail to reject, that statement, that means there's no relation actually. Okay. But what about if I fail to reject? There is no relation. As a researcher, that will raise another question for me. Do I stop? It's very good to know, by the way, the importance of saying there is no relation. It's a very good result. Do not say, oh, my result in my research, it doesn't have any significance. I'm sad. No, having there is no relation, it's results. It's a result. You telling us there is no relation between X and Y. But it can raise another question for you to having a new hypothesis and keep what? Having another what? Explanations, another theories. So you're gonna start to what? To do explanatory model. Oh, so how can you explain that? If there is no relationship between smoking and lung cancer, why this happen a lot with the people they smoke? What the explanation? How can I think differently? How I change my model to find at the end right explanation and interpretation why they are correlated most of the time. We need to know. So you're gonna start raising another questions. What I'm just telling you right now, I'm telling you, try to equip you with how you think as a researcher, how you think as a researcher. Whatever you are studying, you're studying infectious diseases, cardiovascular diseases, nephrology, and whatever science or whatever field you are working on, nutrition, woman and fetal health, whatever, you have to have that thinking. What's your research question? What's the hypothesis? There's no differences. Examine this. If you reject it, they are significant. If not, fail to reject it, that means what is the other question? Why is this happening? You have a new hypothesis, examine the new hypothesis, and keeping having the cycle till you understanding 100% what's going on. Is that clear?
So, Professor, if we think that smoking causes lung cancer, and we have a hypothesis before starting it, and I have done a research and I found out that there is no correlation between smoking and lung cancer, then I'll say that the hypothesis I have been working on, I have to reject that, and I need to find out the new things to say that, look.
Okay. One of the things is very good questions. What about if the fact that the researcher before me in the field, they say there is a relationship, okay? And they come with something saying, oh, there is no relationship, okay? This is what we're gonna discuss it today about evaluation of causality. Am I right? All these people, they did this research. Somebody did that research as an experiment, like a clinical trial, they done as a cohort, as a case control, and everyone as a fact, they found this as a fact. It's very important to check my causality that I reach. Oh, there is no relationship, there is no causality, there is no differences. Okay. At that, I have to think about coherence. What's the coherence? Is my result, and we're going to discuss this, is my result, it's follow what the other people found? Yes or no? I have to think about this. Maybe I did something wrong during the analysis. Maybe my data, it has a bias. The data itself that I collected, or it's ready to go, it's secondary data, it's there. There is something wrong. Maybe that data is not validated. So I have to see what the difference, what's going on. Okay. Maybe it's real. Okay. And this is what you said. Okay. Can I just approve this for the people? Okay. So can I look at do another hypothesis here and see how, after I look at the, is my analysis is good, the data is good, everything is working good, I'm very confident from my steps. Let's do another hypothesis here and see, digging more. When you say I will recycle, do another hypothesis and the third, that means what I'm saying, I'm trying to dig more. I try to dig more to see the explanations, why I'm wrong, why I'm right, why there's a difference, yes or no. Did that answer your question, Robish?
Yes, Professor. I was just trying to ask this because in some of the cases we find like having one the people who had one or two pack of alcohol every evening. Some of the research papers say this is good for heart, and they prove it. So they are like rejecting the normal hypothesis, but it is not good for health. So how they do it, I think this is how they look for their methodology. If they find everything is right, then they prove the new hypothesis.
Yes, or I
Thank you,
can do
Professor.
something in that case. That case, what you're talking about, it's a very good example. Very good example. For example, alcohol is having alcohol every night. Maybe it's good for cardio, for heart, and they approve it. You try to do the opposite, do, sorry, the study, you found it, no, it's not protective relationship, it's a harmful relationship. Drinking alcohol every night causing the so and so. Everything I'm doing is right. I think it's right. Data is validated. Everything is good. Wonderful. So I say, okay, let me think. Maybe they did it wrong, or maybe they are right and I'm right. How? Let me dig more. Maybe it's regarding the dose effect. Maybe when they did their experiment, they have a very tiny. And when I did, the dose, it was higher. So when I having a hypothesis, right? Hypothesis, it says, oh, if the dose is very, very tiny, right? It can be beneficial. If it's increased, then that level, it's become what? Harmful. Okay, I'm just giving an example like alcohol or smoking or whatever, but that it's a valid talking or dispute, as Robish said, which is a very good example to think about it here. Is that clear?
Yes,
So
Professor.
thinking of, great, thinking about, oh, what the next hypothesis? So the next hypothesis, if the drinking alcohol every day above that particular milligram, or how many amounts, I'm sorry, not milligram, how many the amount, right? the ounce or more the fluid itself, right? That if it's increased more than this, that mean harmful, less, it can be good for the heart. So this is going to be my assumption. Then starting the new hypothesis and try to do the study again from different hypotheses, raising a different hypothesis here. Is that clear? I like your example, Robish, which is helping us here very well to think about this this example. Okay, hypothesis. What's hypothesis mean? It's just scientific assumptions. It just not only assumption, it's scientific assumption, right? That can be what? Tested. So I can test it because sometimes you have an assumption, you cannot test it. So number one, you have to be scientific. It's assumption, right? Scientific assumption can be tested. If you cannot test it, I cannot do nothing about it. If I cannot test the hypothesis, it's not going to be hypothesis because I cannot test it. So that can be tested, right? And it can be accepted or rejected. Accepted or rejected. Okay. Usually, as I said, the zero hypothesis or the null hypothesis. What that mean? You're going to say the null hypothesis are always to say there is no difference. There is no relationship. Okay. There is no relationship between smoking and lung cancer. There is no difference between a smoker and non-smoker when it comes to the lung cancer. This is the null hypothesis. And you do the experiment and see, are you able to reject or you failed to reject? Able to reject, that means there is a differences, and that means it's significant relationship. If you fail, that means there is no relationship or significance here. Methods of difference here. What that mean? Method of difference here is all the factor, which is can be 1 or 2, okay, can be involved here. For example, difference in coronary heart disease. Okay, I'm trying to compare between two things. People that are sitting, sedentary, and non-sitting workers. So if I'm working from my home, online, in the desk, and this is my lifestyle, versus somebody is active, running here and here, his job is different, is not sitting. This is a difference between the outcome regarding coronary heart disease, yes or no? Okay, so the differences between these two conditions. The method of concomitant variations, that mean try to think about the association between the exposure and the outcome. As we talk about the alcohol, that a good example about what? Dose response relationship. Dose response relationship. Okay, that mean if I increase the dose, I can have more frequency to get the outcome, right? So that kind of relationship, you increase dose, you increase the frequency to have the outcome. Another example, number of cigarettes and mortality rate from lung cancer. Okay, somebody having 10 cigarettes per day, one have a package, the whole entire package. I'm not sure how many one in it, but whatever, if you say 20, 24, right? Somebody say, okay, so what I said right now, for example, it's just an example, but when you do to the real research, you have to count by cigarettes. I cannot say a package and let it have it like not clear like that. You're gonna say once, so 1 cigarette, 2 cigarette, 20 cigarette, 30, 40, 100, whatever. Okay, so to be consistent. Okay. Operationalizations, which is basically the measurement procedures. That mean the exposure, I can measure the exposure. I can measure the exposures. That when I say how many cigarettes, I can tell, right, the amount of exposure that you have. For example, when I give you before about living in Harrisburg area in Pennsylvania, and they have that nuclear project there and the air pollution. If I want to compare this between Pennsylvania and North Carolina, we knew the environment here, it can be measured, the it's public data that in Harrisburg, the air pollution measurement, whatever this number, versus Carolina, North Carolina, this number. So I have here a measurement. I can measure, this is measurable, this is measurable, and I can look at the effect on particular outcome or the number of cigarettes. Okay. When it comes to associations, I'm going to say there is no association between X and Y, between the exposure and outcome, or there is association. But do you know what? That association, is it causal, yes or no? What does that mean? There is association, but are X causing Y? Are the exposure causing outcome? Is something, sometimes things happen together by accident, or there is a third party between them. If it's causal, is that direct, causal, or indirect? Or is there something in the middle between them? Okay. Or there is something in the middle, in between them. Okay. So if I'm thinking about somebody obesity, with the relationship of myocardial function, is there anything in between them as a third factor? Is in having the hypercholesterol? Yes or no? It can be a third factor, because hypercholesterol, right, or eating fat, eating food, right, fast food or fatty food, how can cause obesity, right? You're gonna be obese, right, and causing the high risk to have myocardial infarction, for example. Positive associations. That mean every time you have the exposure increased, the outcome will increase. For example, here, people tell somebody, my hair looks nice. That will increase the confidence to him. Oh, if multiple one telling me my hair is nice, I'm gonna feel I'm confident. For sure, not me. Okay. So this will increase the confidence, positive relationship, or negative associations. That mean exposure will be protective to the outcome. So if you get exposed, the outcome, it will be the opposite. For example, if I get more rest, so I have my time to sleep, when you wake up, you're gonna be less grumpy. I'm not gonna be like picky and grumpy, right? So this is a negative relationship. Here, I give you an example about sugar and diabetes. Eating sugar and type 2 diabetes. It's just an example. It's not about fact or not. It's not about fact. It's just to tell you how to think. How to think. I may think, oh, do you know what? There's no associations between eating sugar and having type 2 diabetes. I'm healthy. I'm gonna eat too much sugar as much as I can. My insulin, my pancreas will produce insulin, will take care of it. Nothing happened. Not because I'm eating too much sugar or sweet, I can have diabetes type 2. There is no relation. Or it can say, no. There is a positive relationship, actually. There is a positive relationship. It's non-causal. Eating sugar is not causing diabetes type 2. However, it happened together for somehow. I found out with people that eating too much sugar, they have type 2 diabetes. It's not causal. Okay. It just random happen. It can be either the third factor in between them, but I cannot tell for sure this is the cause. The eating sugar is the cause of type 2 diabetes, but I know they happen together, maybe randomly, maybe there's a third factor in between. What are you going to say? No, it's positive. They have a relationship, a causal relationship. Eating sugar causing type 2 diabetes. Okay, so this is the way how to think between any relationship, exposure, and outcome in any type of research. To put these in your mind. There is association, yes or no? Yes or no. If it's no, it's no. If it's yes, are this relationship, it's causal, yes or no? Doesn't happen randomly by accident, the third factor, or no, this is a direct relationship between each others. Here about graphic representations, and we talked about it last time, so I'm not gonna take too much in it. It just tell you, do you know what? It's very good to using the tools to look at the relationship. We just highlight it here because it's very important to think about it. If you want to look at the exposure and the outcome, to do some scatter plot, okay, some diagrams, or the 2x2 table. 2x2 table. It helps you to get the relationship and measure it, as we learned last time, how to do the relative risk, odds ratio, the cumulative incidence. Okay, so for that scatter plot, we talked about those last lecture about the dose response curve, about the multimodal curve, which is multiple spikes, right? Or endemic curve. All these curves, it help to draw the relationship between the exposure and the outcome. Criteria for causality. If I want to highlight and say, do you know what? How can I assist that causality? How can I say they are causal relationship? Exposure cause the outcome. Health criteria. The health criteria of causality, this is a very good criteria to do a comment between the relationship between the exposure and outcome. Number one, to think about it, the strength. If they're causal, yes or no, you can tell by the strength relationship. Every time this happened, the exposure, somebody exposed, they get the outcome. Right there. Boom, boom, strong relationship. Or no, not every time somebody get exposed, he get this. Okay, some pregnant woman taking, for example, particular okay, let's think about this. The folic acid in the first 2 weeks or 3 weeks. If the woman, she didn't have a folic acid in 2 weeks and she has a deficiency, folic acid deficiency, they're gonna have a baby with neural defect or fatal defect in the spinal cord and the spinal cord to be exposed out of the body, yes or no, and it has many degrees to think about it. So what we call it neural defect here. So not having folic acid or deficiency of folic acid and this is a very strong relationship. I may comment too about the consistency. Is every time you get exposed, you have the same outcome? Is it every time the lady or the pregnant woman, if she is white American, African American, Asian, from Middle East, from wherever, and every one of them, they have deficiency of the folic acid and they didn't took the pills in the first 2 weeks of pregnancy, they get the disease? This means it's a consistence. Okay, I may think about specificity here. Association is contradict to particular disease to the exposure. If I'm taking the medication, the folic acid is contradict to have that neural defect in the baby. It's contradict. Okay. Temporality, very important, very important, very, very important. Temporality is regarding the time. Is the exposure happen first before the outcome? Yes or no? Because if the exposure happened after, can you say the exposure responsible to the outcome? I can't. I have to have the exposure happen first, then the outcome. I'll call it temporal relationship. Exposure has to happen first, then the outcome after. Temporality. Sometimes we're going to discuss the when we discuss the methodology in this lecture and next lecture, as one of the disadvantage of many of the study design, cannot examine temporality. I give you example, cross-section study. What's a cross-section? Cross-section, I'll come to the community, boom, snapshot here. Tell me how many one of you guys have a smoker and how many have lung cancer. Boom. So somebody can say, we are 1,000 smoker and 3,000 non-smoker. How many get lung cancer of the smoker? How many one out do not have a smoker? They didn't have the lung cancer. So basically, I'm just looking to a picture, cross-section of the community. Can this data tell you, are these people, they are a smoker first, then they get the lung cancer? Or they get the lung cancer first, then they are a smoker? Can that study design cross-section coming to the community like this and tell me how many smoker and how many have the lung cancer to tell you which happened first, X or Y? Maybe they are getting lung cancer and after that he started smoke. I know there's a good relationship between smoking and lung cancer, but when you examine something new, X and Y, you didn't know the relationship, you didn't know which happened first. So cross-sectional is not good example to examine the temporal relationship or temporality. Is that clear? Okay. Biological guardian, which we're talking about the dose response curve. Increasing exposure will increase the outcome. Plausibility. Does that relationship like seems reasonable? Okay. Eating chocolate make me more smarter, or eating fat make me more smarter. Is it reasonable? Okay. I have to think about it. Okay. So do not get any research question out of the sky, anything. If you eat every day 1 kilo of fat, you will able to fly in the sky. What's going on here? Is this reasonable? What I'm saying, it doesn't have anything to reasonable to common sense. No. Okay. Coherence. This is what we talked about. It coherence is my data. I having the cause and outcome relationship. Is it consistent with the other people discover or the fact? Yes or no? Is it experimental? What's experimental? Does what I did or that relationship can be experiment, or can I put it in an experiment? Here we're talking about, for example, clinical trial. Because clinical trial, one of the top approve, right, to look at the relationship, because I can manipulate it. Different from I have just data in the table, looking to the data or secondary data. I cannot manipulate nothing, I cannot tell nothing, but at the clinical trial, I can say, I can match groups, I can look at the dose effect, I can know exactly how many want to get exposed for how many cigarettes to cause the disease. I can control everything. I'll look and follow up till the outcome happen. Analogy, it's basically comparing between known associations like smoking and the lung cancer, and look at if the tobacco can also cause lung cancer, or chewing the tobacco is different from smoking like a cigarettes. Let me see that. Try to compare the relationship of known versus unknown one. I know I give you examples for two known, but you may get something close, particular kind of smoking to the regular smoking, for example. Analogy. Okay, is that clear? These criteria, put it in your mind. What I'm doing right now, I'm trying to make sure to equip you with how I think, how researchers think. Do not take it as just talk. It just talk. No, we try to give an example for this reason. Try to make you, because to be honest with you, all these example, all these thoughts, it's fact, and I can manipulate it in any type of research. If I'm equipped with the regular or common sense thought, that this is a skills. It's a skills. I can use it in any type of research because you equipped how to think. Okay. Here this study to tell you, oh, do you know why the association, it's look like the jury or the judge to judge between, oh, if eating a burger, for example, and with high fat can cause the disease. If the burger is guilty in that or innocent, no, it doesn't have any relation to it. So I'm trying to see the cause effect burger and outcome of the disease. Another example, causality relationship between Zika virus and microencephaly. Microencephaly, which basically is small head, as you can see. This normal head should be here, for example. children, they born with very small brain, as you can see. Face is okay, but look at the brain part is what? Very tiny and small. They found a relationship, a causal relationship between a Zika virus, pregnant they exposed to the Zika, and the baby, the baby born, the born baby at that time for that pregnant woman, they found women they get exposed to Zika, they have microcephaly. Is a causality, it can be multiple things together to get the outcome. Yes. It can be multivariant causality. Yes. Can be a model. Yes. When we think about diabetes and myocardial infarction, yes, they have a relationship. But do you know what? Getting all things together, making the relationship more strong. Somebody have hypertension, diabetes, old age, right? Obese, all these together, right? It increases the association to what, or the risk to develop the disease. It's multivariant causality. So I will look to different things. I will look to that example, or I'm gonna look to the smoking, family, history, lifestyle, environmental, like web, as you can see. I'm gonna look to different things all together as a model, and that can cause increase the risk of the outcome, yes or no. Sample versus population, we talked about that concept, how from a sample I can draw conclusion to the populations, right? And how, when I do that, what we call it, we call it inference, taking from the sample generated to the public. I can tell this sample is inference to that population. To determine this relationship, you can have a point estimate, confidence interval estimate, or statistical power. Okay. And point estimate here, okay, it's only one single value in the sample that it's choosing to present the population. It's mean I will check only one parameter here to use it as an inference to the populations. Confidence interval. This is, you're going to learn more both power and confidence interval, and in epidemiology that I taught what's called measure in epidemiology. The course is called measures. Yes, we talked in this course about in the second chapter about the measures of epidemiology, but when we do the whole entire course called measures in epidemiology, one of the advanced epidemiology course, right? You learn about the statistics, how to do the models, and more details. It's very strong and important course that you take it as to think about which model I use, which type of analysis, and based on the exposure and outcome. I taught this I think in the last or the previous semester. Okay. Confidence of interval, if the confidence of interval within the particular limit, that tell me how strong I am to judge the relationship between exposure and outcome. You're going to learn this in examples in the next level of the course. Power, which is the p-value, less than 0.05, how this is a very strong relationship, and we say it's a significant relationship. As a conclusion, causality is very important, but it can be very complicated. You cannot say one factor correlate to the outcome, can be multi. Okay, what examine this relationship to, as we said, the confidence interval, the power of the p-value. Any question? Any question?
Professor, by learning this, what we understand is this causality, like the causing factors which really affect the research finding, right? These are the things which will be associated with either it may be the single factor which have or multiple factors, or may have some power association, may have a statistical association, but these are the factors which affect our outcome of the research, right? The
Exactly.
learning of relations.
Exactly.
Okay,
The main things here in that lecture to know is there is a causal relationship, yes or no? How can I judge it? And how I measure it. And when it comes to how I measure this, it's more about analytic part, about the advanced, which you took on the p-power, the p-value, power, and confidence interval. And this is going to be more in the second level of epidemiology course, which is measures in epidemiology. And the main things, as I said, to be equipped, how to think about this. Okay.
thank you, Professor.
You're welcome. Now I'm going to continue talking about the method of epidemiology. This is one of the most important, this class and next class. Okay, especially next class. Now I'm going to give you the most important things, then we're going to move even more further next class. But I will talk about important foundation here in that part. We're going to learn about descriptive methods, and I'm going to give you a hint about the other methods that we're going to learn about it next class. Okay, when you do any research, it's very important to think about the person, what's your populations, okay, the place where the health event happened, is it in US, it's global, it's local, it's in a community, and the time, if this has happened through a period of time or just events spikes, okay. When you look at the disease status, as a disease status, what's your comment on the disease status, which I'm talking about the outcome here. For the outcome, I can say, this patient is diseased, yes or no, or I didn't know, right? Regarding the disease, is the disease recurrent, yes or no? It goes and comes. Okay, is that related to a period of time? Does it happen like through a period of time, or just, as I said, spikes? Okay, I will show you a good slide to explain this. This slides. Look at here. A population or people, they are not diseased. They are at risk to develop disease. That means they are healthy, but they are at risk. They eating junk food. They not practicing walking or exercise or sports. They have a lot of things that put them in a risk to develop disease. But they are not diseased. Here the disease hit with the time. Boom. Now this group of people become diseased. If they are diseased, they are no longer at risk. And this is a concept we learned last time. At risk, they mean what? The people, they are not diseased. At risk, they are not diseased. When we say Can you see the prevalence, right? And when we talk about the percentage of 1,000 patient, 100 they are diseased, right? Can you calculate the incidence, not prevalence, the incidence? He said it's 100 divided by 900, because the 900 at risk who do not develop disease. But once they are diseased, no longer at risk. They're already diseased. They developed the disease. So it's very important to understand the disease status here. Okay. Recurrent is the disease. Recurrent come multiple times. And if it's recurrent, does it take a period of time? I had a COVID. It takes 2 weeks for me to be recovered. Then I get it again. I get exposed again and again. But it takes times. It's recurrent and takes times, right? Here recurrence, but as not disease status, as event. I get it multiple times, but you know what? It doesn't take a period of time. Somebody have a pain in the tooth. It comes right there, then disappeared. After 2 days, comes again, then went back. Takes there's no a long time. It just in events happen of pain, for example. So you have to think about these in your thinking, these concepts in your thinking. The most important slide in the whole entire chapter today, and you're going to see that slide next in the PowerPoint of the next chapter. Okay, this I will share the publication that I have. This is one of my publications, okay, that I'm trying to publish to make you guys to think the study design, okay, this one here, to know what's the possible study design, what the advantage, what the disadvantage for each one, This is the most concept in the whole entire course, talking about the study design, what the advantage of each one is the disadvantage of each one. For that reason, in the future assignment, we're going to give you an articles. Please tell me what the study design, right? Critique it, what the methodology, it's skills to learn. So when you're starting your research, you will be clearly mindset, boom. This is the most important slide, and that I will share this with you guys. I want you to study well. That paper, I'm going to share it, okay? If you study it well, it covers the most important part of the material, which is how the study design or research methodology or epidemiological methods, okay? When you think about study or study design, there is two types of research: primary research, secondary research. Let me talk about primary research first. Primary research, are you doing what we call it wet lab or wet research or bench research? Is your study, you have to be in the lab and do some protein analysis, look at the DNA, look at the animal study, cell study, biochemistry study. Are you in the lab? If you're required to do this in the lab, we call it a wet lab or bench research. This is what we call it basic science research. I want to look at the cells, cell structure, the effect of particular thing in the cell, look at the DNA, look at the protein synthesis, basic science. Sometimes I do transitional research, moving from getting a concept from the basic science and move it to the bedside, to the clinical here. So how can I get something from the lab to think about something in the lab? And I turn to a model, real transitional to real fact in the human to approve it and to have an effect from the clinical. So transitional, moving from what? From the basic science to the clinical, to the bedside, to the patient. That transitional from here to here. Clinical research, no, it's all my study. It's on the patient. I do my study, and this is what we're gonna focus on, the main one here to focus. You're talking about clinical research. I gonna done all my research in the human, not in the animal, not in the mice, not in the pigs, nothing. It's just in the human. Okay. When very important, these thoughts is very, very critical. When I'm trying to study something in the human, exposure and outcome in the human, it's very important. Are you, as an investigator, assigning the exposure? Are you assigning the exposure, or the exposure happening in its own? If I'm assigning the exposure, it's experimental, which is clinical trial. If I'm not assigning the exposure, I will call it observational study. I didn't have anything to do with exposure. Example, smoking and lung cancer. If I'm studying smoking and lung cancer, if I get people, they are a smoker in their own, and other people, they're not smoker, and they follow up these patient as they smoke in their own, right? I'm doing observational. I'm just observing. Different from I get in two groups, and the first group, I give them cigarette, tell them this is e-cigarette. I want to examine the e-cigarette when I decrease the nicotine by the e-cigarette versus people, the not smoker or smoker, regular smoker, and other people, I'm giving them e-cigarette. I'm assigning. It's critical to differentiate between the clinical trial and the whole entire other study design. Am I assigning the exposure? Ask your question always. I have the drug and placebo, giving the drug and placebo. If I am giving the drug and placebo as an investigator and comparing and follow up them, it's totally different from I getting people, they already taking the medicine A and another medication B, and I compare between them. I'm just observing. I didn't give them anything. I didn't assign exposure to them. So remember very well, assigning exposure is clinical trial. We call it intervention. We're giving something we gave as investigator. Is that clear? Is that concept clear? If you look at the clinical trial or experimental, it's very important to say it's random, yes or no. Am I choosing a particular group to assign the exposure versus another, or just random? If it's random, it's high quality, better study, right? Random, which is randomized clinical trial versus non-randomized. I know I'm gonna take particular people with a particular characteristic and give them that medication. No, it's better to be random. Okay. Coming back to observational study, I know I'm not assigning what? I'm not assigning exposure. This is the most important critical question. The second important question in the observational, do I have a comparison group? I'm comparing between two things. if I am comparing between two things, that means I'm going to do analysis, the difference between them. For that, I call it's analytic study. Analytic, I will do analysis. I have to group. I will do analysis between them. If not, if there is no comparison group, all right, I will say descriptive. And this is our class today about descriptive, that group, descriptive. I didn't have two groups. I'm just describing something. I'm watching something. I'm just describing it. I'm not comparing between two things. Like what? Case report. I just have a case to describe, or case series. I have case or cases to describe. Do you know what? I have that rare disease. A patient come with a rare disease. I give him that particular medication. And do you know what? It works and he has been recovered. Rare diseases. The doctor didn't know how to deal with it. Okay. And I had a case in my clinic. I gave him that medication and it works and recovered. I'm just telling everybody, do you know what? I'm just describing what's happening, or not me giving the medication. I'm giving medication here to treat. I'm not to give medication to compare two things as we have here in the clinical trial. If I have that patient with another patient, I give this medication and this is no medication, I agree. But we have a case. And that case, by the way, can look into the data. Oh, do you know what? I found that patient, he gets recovered once he's getting that medication. Or ecological study at groups. Ecology, and it's mean ecological, it's mean groups. All what I'm doing here, just describing. I'm not comparing, I'm describing something happened for the people, so the people to know about it, what's going on here. But for analytic part, I'm comparing two groups. By the way, E and O, exposure and outcome. Look at these three, I like it. Why? In cross-section, the exposure and outcome, I'm evaluating exposure and outcome at snapshot, at particular time. Boom. Coming to the community, how many of you guys have been smoker, and how many guys have lung cancer? Even I cannot tell which you have in first, is E or O. I cannot tell. This is called cross-sectional. I'm comparing between a smoker and non-smoker for having lung cancer. Yes, I agree, but as certain point. Case control. Look at this case control study. I'm going to just to give some elements. We're going to go more deep next class, but now to make sure your brain have been formulated, got it in total as a framework, Case control study. Case, it has that letter E, right? E, it's mean exposure. That mean I'm looking to the exposure. I'm trying to find exposure. What does that mean? That mean I have the outcome. Patient, they have lung cancer. Patient do not have lung cancer. And look back here. Look back to what? The exposure. Why they have lung cancer? If this is regarding, look at the exposure. Smoking. Is it air pollution? Why? So you have, when you design group have lung cancer, group have what? No lung cancer, and to compare between them regarding the risk factor. Go back and study the risk factors. This is what I call it case control. I have a case, lung cancer, control, no lung cancer. Look at the difference between two groups by looking back to the exposure or the risk factor. For that, I say, case control. Having the outcome, looking to the E. Outcome, looking to the E. Case control. Cohort is different. I'm looking to O. Look at the cohort, it has letter O, right? I'm looking to the O. So if I'm looking to the O, that means I have risk factor. People exposed, people not exposed, exposed, non-exposed, and looking if they get the disease, yes or no. If they get the outcome, how many of the exposed and non-exposed get the outcome. So A, looking to the outcome. I have to think it's A and I'm looking to the outcome. But do you know what? In that cohort, I have the A exposure, exposed and non-exposed, and looking to the outcome. It can be done by two ways. It can done prospectively or retrospective. So prospective or retrospective. People, they exposed and non-exposed. Okay. Then I follow them in the future, right? If they get the diseases or no. I will call it prospective cohort study. Prospective cohort study. People exposed to smoker, people do not smoke, not exposed to smoker. So smoker versus non-smoker. Then I wait. I follow them. I have two groups. I'm gonna follow them. Waiting 1 year, 2 years, 5 years, 10 years, and after 10 years, do you know what? Out of the smoker, I have 60% they develop. Non-smoker, 20% they develop. So I have to look to the future. Having exposed, non-exposed, look to the future. I still looking to the outcome. Another way to look at the outcome, you may look, you have look exposed and non-exposed, but you look back. How can I look back? I have already data. It's collected data. I have data. It say this patient exposed, and he have the lung cancer, yes or no. Second patient exposed, having lung cancer. Is the data is there already? It's collected data. I didn't have to wait to look to the future. It's already collected data. It's data in the hospital, in the electronic record, for example. It's secondary data. It's collected. So I know the results. But I'm gonna still look at the exposed and non-exposed, right? And look at the outcome. But I look back because I have already the data. I have the data telling me the exposed and non-exposed. This one is what? These have a lung cancer, yes or no? I didn't have to wait. I have the data. For that, we call it, we look retrospective. It's already, the data is already collected. It's collected data, secondary data. Is that clear? Is that clear for you guys? Any question? Very important to absorb this. Okay. I'll keep talking here about secondary research. Here, actually, I'm not doing any of these. Do you know what they're gonna do in secondary research? I'm gonna look at what the people does or done. Person A or the researcher A, he done a cohort study. Researcher B, he done a clinical trial. Researcher C, he does a case control. Talking about the same thing, the relationship between smoking and what? And lung cancer. Then I come and do systemic review. What's systemic review? I will look about the result for each one of these researchers, these three researchers. Okay. And see the result, what they said, what they said, what they said, what they said, what they said. So basically, as you're doing summary. So you have a paper to tell that researcher said this so and so, and his result like this. Second researcher, his result like this. This. Out of all these 100 studies, my conclusion, based on reading all those, I will tell you, I will go with that result. Systemic review. It's very high evidence. Sometimes I get more further. What? More further? What you do? I do meta-analysis. I will taking these 100 studies and do analysis between them. not just by reading and giving my impression. No, I use the analysis. Look at the how many patients here each study used, how many smoker here, how many non-smoker for each study, weighting the study, the value, how the weight of each study using analysis. Maybe somebody have a clinical trial, which is so strong. Can I make this equal to somebody have a case control? No, everyone has a different weight regarding methodology, regarding the population, the sample size, regarding the analytic. So I look at all these and do analysis. This is the highest one, meta-analysis. Okay. A question.
Yeah, Prof, I have a question. Thank you very so much for the lecture so far. But I want to find out what actually differentiate a case control study from a retrospective cohort study.
Very good. Both retrospective, right?
Yeah.
But the case control, I'm looking to the A. That mean I'm gonna classify my study. Lung cancer, no lung cancer. Then looking to the risk factor. Yeah, it's back, but I'm looking to the risk factor.
Okay.
In the cohort, yes, I'm looking back, but I'm not classifying them case and control. Disease and not disease. Lung cancer and not lung cancer, looking back. No, I'm classified differently. I have exposed, not exposed, which one having the outcome.
Yeah.
I'm looking to the outcome. In a case control, I'm looking to the exposure. I'm trying to investigate the risk factor. In the retrospective cohort, I'm trying to look to the outcome.
Okay.
Is that clear? It's very important. Very important
So,
question.
Thank you very
Professor,
much.
like basically speaking, a cohort study will be dealing with the population, entire population, and the outcome of the research, right? And talking about case control study, we have two different groups. One is exposed to the cases, exposed to the smoking, for example, and another is not exposed. And we are looking at the exposure.
No. Let me clarify this. Number one, in cohort and case control is not entire population or not entire population. I have two groups.
Okay, we have two groups in both. Okay.
In cohort and two groups in the case control. In both study design, I have two groups, but I will classify them differently. In the case control, the two groups classified based on the
Exposure.
case and control, based on the disease. Case, control, disease, not disease. Then look back to the risk factor. Tell me what risk factor causing the disease. In retrospective cohort, I have two groups. I'm classifying them based on the disease. No, based on the
Outcome.
exposure. Exposed, not exposed. How many get the outcome, the disease? Is that clear?
Yes.
Yes, Professor. Thank you.
You're welcome. It's very important to know I'm classifying the two groups based on the disease or the exposure.
Yeah.
Okay. This is the most important slide. And when I told you I'm going to share the publication with you, because believe me, the publication, I was made it actually to the people in the laboratory, because I was working as a research scientist and in the lab, in laboratory, and they are not, it's a new thing for them to work in the research for the whole lab in America. If you heard about lab 2.0, they try to change the era of the laboratory people. Every time laboratory people, they do what? What they do, blood analysis and deliver the result for the physicians. They not participate in the research. What we call it is what? Sample in, result out, sample in, result out. They not participate in any kind of research. And this is what's in America right now, moving from, do you know what? Are we just giving volume of a sample out? We need to add value. how we need to equip our lab scientists, lab professionals, doctor to learn about science, about clinical research, so they can what? Add. They have most of the data come from the lab, right? But they're not using it, just giving to somebody else to use it. Then that lab 2.0 tried to change the mindset in the whole entire America. And I was a member in that group, which including now around more than 20 hospitals. Okay, so I was leading that part of the sepsis in that project. So I published this as important resources for anyone want to get involved in clinical research. If you want to think about study design, this is what it is. So that paper, when I share it, it's going to be like your important resources at any time you want to do a research, because it talk about each study design and the advantage of each one and disadvantage of each one. Very critical to know that slide. Any question before I move forward? Okay. Are these study design all have the same value? Or there's one more authentic than the others, more advantage, more powerful than the others? Here's the hierarchy of the evidence. What that means? Look at the top, meta-analysis. This is the top evidence, the most important evidence. So if you have meta-analysis for a topic between exposure and outcome, you know what? Very high evidence, which when I talk about what? Not doing only systemic review, I'm involving that analysis between these studies. Doing the analysis, not only systemic review. Second one, systemic review. I'm not doing the analysis, but I'm judging every study in that topic and giving my impression by after reading everyone. Then the experimental randomized clinical trial. These are randomized, these 1, 2, 3, 4, as you can see, they are in order. Quasi-experimental studies, still it's a trial, experimental, but it's not randomized. It's not randomized. Randomization give it higher rank than non-randomization. Both they are clinical trial. Then cohort study is more powerful than case control study. Then the last one is just case series. It's very important to think about this also as an evidence. So when I do my study, which model I'm gonna use? I'd like to use something give more power, more evidence, right? So you can tell, I'm gonna do case control or cohort. No. Clinical trial. For sure, each one has advantage versus disadvantage. A lot of factors will play roles. Time, for example, having money to do the things, yes or no. Time consuming or need a lot of money. Patient, the type of the nature of the disease. Is it rare disease, yes or no? Many things play roles. Sometimes you feel I'm very limited, I'm tight. Why? I didn't have money. Very limited in the time. Rare disease versus maybe it's hard to find the patient to work on them. Only have a couple cases. One case only, so I have to do case report. But they're going to compare what to what. That's what I have. So the resources is very important. Okay. Clear? Descriptive study, I'm just describing no analytic, this group. Because in this class, I'm gonna learn about descriptive, next time, analytic, and clinical trial, okay? Descriptive, it can be valuable for other studies. For sure, any clinical trial, case control, or analytic, there is a descriptive study. Talk about it before. What does that mean? Case study can lead to, I have just case study, one case to report, but it can lead to a research question and then move forward to analytic, right? So it's good to use to conduct additional study. Okay, it's the first level to give me some clue I can move forward to more further studies. Okay. What's the aim? Permit evaluation of the trend. It can give you a very good clue about trends. It doesn't gonna approve any causality or temporality or no, not at all. Not at all. Right? It's just to give you some information. You're describing, give you information evaluation of the trend or health services, identify a problem, right? By the description, you can find gaps. These gaps, it can be a research question that I can use a case study or a case control study or cohort or clinical trial in the future, but it helped me to find gaps. It's the first preliminary tools. Case report, case series, cross-sectional study. Look at the case. This is part of the paper, that table, part of the paper. Study design, description, what's the advantage, what's the disadvantage. Case report and case series, they describe the experience of one or more people with the disease. One case, couple cases, it describes only description and only one case or a case series. I have multiple patients to describe. Advantage, look at this, first alert of new disease or condition. By study just one patient or couple of patients, it gives you the first alert. Oh, I need to study this. I need to look at more group. I need to do comparison. I need to approve it more. It gives you the first alert to tell you about, let's think about it. It can help it to generate the hypothesis with the research question. As I say, the gaps. It's very useful. And I can say case report, very useful when it comes to a rare disease. And new disease happen. Like what? The first case happened in the COVID. Detected in the COVID. Oh, let's do it. It's time to do the case report. It's a very good time. After that, I'm gonna have a lot of COVID cases. We compare between COVID and COVID, but the first case, a rare case, a new case, it make a big difference. Before in COVID, they thought is what the SARS. It goes and it damages the elastic fibers of the lungs. Okay, but later they found the elastic fibers in the lung is intact, is no problem. And more it's about clotting, consume more clotting factor, right? Causing to the bleeding and clotting. You find even the tubes in the COVID at that time, it still is a clotting factor. It's just you find the tube and it has the blood and that blood is just clotted. The DIC, disseminated intracoagulopathy disease, a lot of clotting in the vessels. Okay, they start to describe it in the letter. I remember the first paper, it was a letter, half a page, talking about that concept. Okay, disadvantage. What's bad about case control or case series? Lack of comparison group. I didn't have to people to compare between them. Cannot determine cause-effect relationship. I cannot say a causal or determine the causality. Can I assess disease frequency? How frequent the disease is? It's very rare. Okay. So these two descriptive analysis, descriptive studies. Cross-section study. That mean I have the exposure and the outcome, but I come to the middle, like cross-section, as you have something and you cross it. Have a cross-section. Let me look at it. What's going on here? Just a cross-section. You're not aware about the period of time between the exposure and the outcome. You're not looking to the period of time. It's just cross-section in the middle. So think about it. People, the exposed, non-exposed, outcome, right? And the process is going to develop the outcome. I'm not going to care about that. It's just a snapshot, a picture, cross-section in the middle. Boom. How many have a lung cancer? How many is a smoker? In the middle, right? We call it always study the exposure and outcome at the same point of time, snapshot. This is good about generating hypotheses like this one. It's good because it's quick and easy. Just cross-section. I'm not going to follow anything. I'm not going to do analysis. It's just number. How many smoker, how many non-smoker, how many have the disease, how many not having the disease, right? It's very good to have prevalence. I can study the prevalence, estimate the prevalence easily, how many disease versus the whole entire populations. So I can study the prevalence only as a study to help for future further study. Okay. Maybe used as descriptive or analytic. I can use it as analytic, right? It can be, but most of the time it's just descriptive study. What about bad about this? Cannot examine temporal relationship. I cannot tell what's happening first, the exposure or the outcome. I'm just having a snapshot. Cannot tell who's first. Who's first? Okay. Can I estimate incidence? Can't estimate incidence. Okay. Case report. All this is the most important things, that table. You're gonna find some comments as we go for each one. So let's go with the case report.
Professor, can you give us one example of cross-sectional study, like best example, and what we cannot like differentiate?
The cross-sectional, exactly the same when I said about the smoking and lung cancer. I just come to the community. You just go to the community you live, okay, and ask them to do a survey. Hey, tell me how many of you guys have lung cancer? How many of you are you a smoker, yes or no? Collect that data, okay. By collecting this data, you're gonna have 2x2 table, smoker, non-smoker, diseased, not diseased, 2x2 table, right? You didn't know which one is having first. Another example, eating fast food and myocardial infarction. How many of you guys are eating fast food? How many times, for example, right? And do you have a myocardial infarction, yes or no? 2x2 table. Okay. I cannot tell what's happened. Maybe somebody has a myocardial infarction before he eating fast food. Okay. You cannot tell what's happening first because it's just snapshot. I'm now giving you a common sense, which is I know smoker causing lung cancer, eating fast food causing myocardial infarction. But when you study a new disease or new things, you didn't know what the relationship, X and Y. I didn't know what X having first or the Y first. Or what I know, how many of X having Y, how many of Y having X. Okay.
So, Professor, how do we select the accurate case study, this epidemiological study, to get accurate results? How do we select to?
Out of those. Is that what you said?
Yeah.
Okay. When you talk about the study, what it's about limitations. It's not about accuracy. Accuracy based on the data. Yes, for sure. Some study have a higher rank of evidence for that. We have this. We have the evidence. The way I did this in meta-analysis is more stronger than case control. For that, we put this in order to tell you this is the best way to done. Okay, but at the end, it's based on your resources. Okay, so if you don't have money, you cannot do clinical trial. I can't. Okay, so I have to look what's underneath them. I give priority for cohort. Do you know when you cook food, chicken, for example, there's a multiple way to do chicken. Okay, multiple way to do chicken. Is it barbecue? Is it tandoori? Is it grilled? It's whatever. Each one has its own way, right, of cook, right? To tell you which one better taste at the end, or better quality at the end, or how fast we're gonna get the chicken done if you are hungry, okay, based on the resources that you have. Okay, so put in your mind when you choose two things: what's your resources, what's the proof of evidence here? Is that
It's like, can we have any document or something like that in the resource section to, for each example, for each and every study, to get more for better understanding
no,
for
is
each
not
study? For each study, can you give any one example for each study so that we can have a clear idea for each and every epidemiological study in the resource section?
okay. This is what I used here. I want to go in order, so I give you examples for descriptive, and I'm gonna go more further for the others. But this is what I thought I'm talking about here about lung cancer and the smoking. Okay. Let's see about case control. Sorry, case report. As I said, the first COVID case. I'm very limited. I didn't have any population they have already had disease before. It's just one case, and I want to study the complication or outcome. I did not have any population. I will focus in that study. Then I have multiple people, they get COVID. So I have multiple cases. Now I can compare cases to cases. Cases only, not population, not groups, cases. So I will think about, oh, let's do the case series. At the first one case report, this is the only one I can do. I didn't have any other option about resources here. Then I have multiple cases. Oh, now I can do case reports, case series, multiple cases to look to the COVID and the mortality rate. Look at the COVID and symptoms, for example, of the COVID. For example, if I study the symptoms in case control, in case report, I'm describing what the symptoms and what the complication I had in that case. This is the only case I had. I have multiple events, multiple patients. Now I have 10 patients. They have COVID. I will start to study what complication, symptoms, and compare between the complication and symptom for each study. And the end result, what the complications. Now I have all the world now have, for example, in China specifically, people they got before they moved from China to other place to the whole entire world and become pandemic. I said, you know what? Let's look at the cohort, the people, and in China right now, and look at the people they have a COVID versus people do not have COVID regarding the complication outcome, the percentage of people they bleeding, or the new mom they are pregnant. This mom they are having COVID. Okay, the other mom do not have COVID. Okay, let me look at the new babies here before it moved to another. It's just cross-sectional. Do you know what? I have 100 mom, they have COVID, 100 mom not have COVID, the baby already born. I have the data for this, a cross-sectional. Tell me how many of these baby have congenital anomalies, have problem, a defective problem. So this is one example to tell you how we are moved from case report, case series, cross-sectional. Do you think that answers your question?
Yes, Professor.
Great. So I like that the example you ask. Even I thought about the lung cancer. They did give example of the lung cancer, but your question make me think more and make me dig more in my mind what the best. So I think COVID is a good example to move through these study and give better example, by the way. So thanks for asking the question. Case report, I think we killed it, right? Yeah, it's just some examples here. You can see it in the Yellowstone National Park, but we give a very good examples. You can find some examples in the book to look at it. Okay. Case serious. Now I'm talking about what multiple case. Look at reported case. Like here, how the report in 1937, okay, the meningoencephalitis, okay, and now I have 121 cases. This is not only one case, so I can do a case serious study, and I'm comparing regarding the trend of these cases. Cross-sectional, as I said, is snapshot, just point of time. It has to be at a particular point of time. Okay, it's very well known about prevalence study, because when they have cross-sectional, I'm gonna say in the cross-sectional regarding the COVID pregnant mom with the COVID versus non-pregnant mom with versus a pregnant mom with no COVID, I can say I get a cross-sectional how many congenital anomaly in the cohort of the people that have COVID or pregnant women have COVID versus no COVID during pregnancy. We study the cross-sectional study, advantages and disadvantages. Here, another cross-sectional study for surveillance. Here, to look at the prevalence through the healthy sleep patterns among American. I just try to compare between different states regarding the sleeping pattern. Cross-sectional, I'm just going to ask a question for everyone, survey. Boom, I have data. I can study very easily. It's expensive. As I said, regarding descriptive, it's one of the most important thing as advantage. We talked about it, generating hypothesis, initiating the new information to detect or to use a different study design. So we consider as foundation. You start with this first, then you go more further to the next level. Here you're talking about descriptive epidemiology that we say. It's just a summary. Who, what, where, these questions, right? Rule out something random by chance happen. Discuss biases that having, if some have a bias or confounding factor. Okay, when I say confounding factor, remember when I said I'm studying diabetes with myocardial infarction, for example, right? And I want to know if the hypertension, gender, sorry, the age, it's increase the outcome, yes or no, increasing the outcome, yes or no. So I have to control for the other ones to make sure I'm doing one-to-one relationship, diabetes to outcome, controlling for the others. This is what control, confounding factor, controlling bias. Control bias also happen during the selection, when you select the sample and during the analysis. This is, we're going to study more confounding factor, biases in the advanced course of epidemiology, which is a measure of epidemiology. Okay. Descriptive study here, the regarding interpretation. Descriptive study shouldn't have analysis except in the core and cross sectional. It can have analysis. Okay, you have the hypothesis here. Okay, if you look here, that part is analytic. Okay, we have to control for the same thing, do the same thing here. The only difference here, analysis for sure, and to comparing groups here, not. To be honest, the best way, this is from the book, but I highly recommend you, when we study descriptive, just focus on one slide, two slide, that slide. If you study the three slide, the descriptive all is covered. You understand it well. This is all just some example from the book. If you highlight exactly what I said regarding the three slide, remember what I discussed, the example I gave it to you. Okay, this is, you master it. You master it very well. But this is still some slide to give you more insight and help if you look to the study have published in each one. Okay. Person variables. For example, here I'm going to talk about the person and the time, right? For person, you think about the person, you want to think about anything related to the person: age, sex, ethnicity, socioeconomic status, marital status, the place of origin, nativity, and migration, religions, all this regarding person. Okay, so let's talk about first thing here as an example. For example, look into the age. Age is a very important factor, by the way. You have to consider it in any analysis you will do. Age is very important because many things change by age. For example, your immune system changes by the age. Why elder patients, they are hitting more during the COVID? Why? The faded immune system, weakened immune system. Okay. Many things, body mass index in the baby versus the adulthood versus elderly. Many things change by age, so the age is very, very important and very descriptive factor to describe, to say, do you know what, I found the mortality rate increase and the people have COVID in the people above 60, as an example. Okay, here give you the cancer related to the age. What happening? Age, cancer, the age increase with what? Old age. Example for another examples, more than what we discussed. Okay, about how mumps and chickenpox happen in the childhood versus other age, how that age sector in the children is very important. Okay. 6, also another important factor to see the 6 differences. We're talking about nature. When you talk about age, it's nature. As you grow, things change. The same thing. There's a difference between male and female. The structure, the physiology is different. When you talk about hormones, when you talk about finding the ovary, having more estrogens, the menstrual cycle, things different. So that will impact the outcome. So it's very important to look at the 6 differences. Even cancer, there's some cancer in the female, you cannot find it in the male, or the vice versa. Testicular cancer, I cannot study it in female, I study it in male, right? Or it can be in the male and female breast cancer, but how it's more high in the female than the male. 6 is a very important factor. Here it gives you some important differences between male and female regarding what the top cancer. Prostate is the most important, for example, regarding cases, right? Lung cancer, so prostate cancer, then lung cancer, the colon cancer, the urinary cancer. In the female, the most important cancer is the breast cancer, then the lung. Different from the male, it's prostate first, then colon the same. Okay. If you're talking about mortality, what causing death, you're gonna find lung cancer in both male and female is the most higher. Then the next higher mortality from the cancer, the prostate in the male, and breast cancer in the female, then the colon is the third one as mortality rate. Okay, so there's a difference. There's a difference. You have to consider 6. Race. Yes, there's a difference. Absolutely, there's a difference. For example, race, white versus African American versus American Indian versus whatever race, many races. Okay, example, African American versus white American. If somebody get injured in face, for example, or in hand, do you hear about keloid? You're gonna find the scar. It's very easy. If African American get injured, he or she will have a scar, which is we're talking about the healing process for that injury, right? You get a scar more than the white American. There's a difference. Even when you talk about genetic, there is many study approve that the white American higher risk in that particular disease, or the African American, they have that higher risk to have the disease. So race play a big role to
Yes, Professor, like in Ashkenazi Jews, there are lots of diseases which are very common to them. Even single breast cancer and these things need to be think genetic in origin. Ashkenazi Jews than other races.
Absolutely. Absolutely. For that, when we study what we call it epidemiology, we talk about distributions, right? You tell me that particular disease is very distributed more in Asian versus a white American, okay? Or African American versus a white American. So I agree 100%. Nativity, which is basically the origin, okay, and of the individual or the relatives, okay. So foreign born or native born, as we have the Native American versus the American, they migrate from Europe to America, okay. So we're talking about the origin to include, okay. Racial and ethnicity. these white, black, American, American Indian, Native, Asian, all these, it need to be included in your study. For that, we move, when you look at ethnicity or race, both, it leads you to genetic differences. Or are we different in genetic, right? Our reaction to the disease is different. And this is actually what led already to think about genetic or study the genetic in and the outcome of the diseases. Reaction was different between races and ethnicity. Thinking about religion to be included, why religion is very important. Practice difference. Practice difference. For example, if you think about in America, right? It's regarding the lifestyle and religion belief. For example, it's okay to practice sex, having boyfriend, girlfriend, practice sex without marriage, right? That, so multiple partner, that put the HIV as a high risk, a very high risk for this group, right? This is regarding the practice. Other religion or other location, they believe, oh, we cannot have sex till you get married and then making sure I have only one partner. Do you think they can have an HIV, right? And what is the distribution or risk of spreading this HIV? Okay, it makes differences, right? Circumcision, some people from religion, they say, you know what, for a male, we need to do a circumcision. For the penis, they take that piece of the glans, right? Just the flapping skin. So the glans will be appear instead of just skin like this. So they take that flap of the skin. They found males with circumcision, they are protected against cancer. Why? Because if the glands covered by that little skin, between the glands and the skin, things can go inside, bacteria will overgrow here. That bacteria can change and causing cancer. They found people, they have that believed to have the male to be circumcised or having circumcision is protected from a cancer versus male not having circumcision. A lot of examples regarding religion. So religion, it's, to be honest, not a lot of cases, a lot of study, they include religions, which is very important regarding practice, very important regarding practice to be included to see is what the difference is the practice. Okay. Still talking about race and ethnicity. How here, look at this. Low frequency of asthma reported among Hispanics. What's the difference? Why Hispanics, they have low frequency of asthma? Non-Hispanic white and non-Hispanic black, less frequent reported. Okay. So you're going to start to find a lot of this. Incidence of gonorrhea is higher among non-Hispanic black than other group. Why? As I said, at the end, you're going to turn us to what? Genetic. Okay. And by the way, a lot of health system now focusing in this. Try to consent the patient. Can you please rule in and consent to having some sample from you, like blood sample, to look at your genetic? We have your clinical record. You know what you have diabetes, this and this and this and this, what disease you have, but we need to look at your genetic, correlate your genetic to the outcome and the other patient genetic to the outcome, comparing between all these patients. I have 100,000 patients, I have their genetic. I can look to their genetic and the outcome, whatever outcome is, chronic heart disease, chronic kidney injury or acute kidney injury, whatever. So we turn to think about genetic. Socioeconomic status, one of the most important things right now, or not important, the most new thinking about socioeconomic status. There is a new course also that it say the social determinant of health. Social determinant of health, a new field a few years ago. Now, if you study sepsis, tell me what the social determinant of health for sepsis. What's the social determinant of health for myocardial infarction? What's the social determinant of health for so and so? What meaning social determinant of health? Let me look at your income. Are you owning your house, yes or no? Do you have your own car, yes or no? Yeah, you're using public transport. How the way you live? Do you have a supporting family? Or are you living alone? How many members in your family? Are you educated? What level of education you have? What type of job you do? All these factors play a role in the outcome in a disease. For example, if I have low income, I didn't have my own car, I'll live with partners, I cannot find money to keep my hygiene, my health hygiene. You find the place is dirty, is of high risk to have infectious diseases. I'm gonna be in more high risk to get sepsis. I can die easily from all these complications. Why? Socioeconomic status. Okay. Here a study about socioeconomic status, mortality and morbidity, about the natural teeth and dental visits. So talking about the poverty level and the dental visit. Okay, as the same example, just I gave it to you. If I didn't have money, I'm not gonna go to the dentist. What's gonna happen? I'm gonna have problem. I have to extract my tooth or do a root canal or health disparity. Very important. Health disparity, the difference in occurrence of the disease and adverse effect or health condition in the populations. So basically, if you think about the cancer health disparity, health disparity, okay? So I'm looking to the people they have a cancer as a new cases versus the existing cancer right now, and looking to this outcome regarding mortality. So basically, I'm looking to the differences in something, anything. Can be a cancer, can be a sepsis, it can be any disease. And this lead to what we call it health inequity. Inequity. What does that mean? Yeah, I know you have sepsis, this patient not have sepsis, or you have frequent sepsis, you get multiple times sepsis. Me, I didn't get this. Health inequity. Why? I have health services. The doctor very close from me, very close to me. I have an access to this. I have money, right? The government in my location taking care us. They have a lot of good programs, healthy programs, good diet. Another location or community is what? No. The doctor is too like 100 miles from them. Well, can I go to the doctor? So I get infected. I'm not going to go to the doctor. I will get sepsis. Doctor close to me. I will go to the doctor. He will treat me. I didn't have sepsis. It's just infection, getting antibiotic. I didn't develop the sepsis yet. I'm good. I'm fine. Health inequity. Making sure every one of us have access to health, right? It doesn't matter your social status. It shouldn't be and this is what the government should do, right? And making sure every one of us having the health services, making sure get the health. You have money, it doesn't matter what's your location, it doesn't matter anything. It should be health equity. And this is one of the big problem right now. Not all the people, they have the same health services, what we call health inequity. Place, very important to include. How I'm doing this, and as I said, when I do the Harrisburg, I talk about the air pollution, the nuclear project versus another place. I have to consider a place. International versus national. Urban versus rural. It's everything is different, right? They have an industry area with air pollution, or just a very farm, nice area, fresh air. Different. Place need to be considered. International have been regulated by, and this is thanks for WHO. Why? It just monitor in a level of the international. Okay. CDC, right? It's in America, right? And it does some work internationally, but the most regarding internationally is WHO. When you study about vaccination in COVID and giving a vaccine for free for countries, WHO. Why WHO want to do this? Basically now the whole entire world become a village, a small tiny village, right? I can have the disease today. I travel from Egypt to America. Now it matter is what's happening in COVID. This is exactly what happened from China to what? America, done. America is done. 1 case, 2nd case, 3 cases, 4 cases. Now, not only America, all the countries, because it's originated from China and distributed everywhere. So 1 case in any country can make a big difference in the whole pandemic. So they care about, oh, I want to see Africa, I want to see Middle East, I want to see America, I want to see Europe, Asian. I just want to control. I just want to make sure I'm regulating things, offering things. So they think from international mindset. Is that clear? Here about the polio and the internationally, right? And how it was endemic in 2013 in Afghanistan, Nigeria, Pakistan, and how we try to eradicate that, making sure there is many places already eradication of polio. There is no, okay, but how this still some country can have an endemic of this, right? National, I'm talking about the within the country, not international. As I give you an example for CDC in America. So you have to think about, look at this environmental pollution when I give you the difference between Harrisburg and North Carolina, or just Pennsylvania and North Carolina, right? Between when it's sitting in another climate differences, right? Arizona is different from New York regarding climate, or Pennsylvania regarding having snow versus no, it's tropical. For that, we say tropical medicine. Oh, tropical medicine, not only in Africa, there is area in the US, like the Arizona, how they have that hot weather and having some tropical medicines or tropical infectious diseases. This here, talking about the age adjustment regarding stroke. So the distributions of the stroke based on the age. Urban versus rural differences. I give you this also about the climate, right? Industrial area, air pollution versus not, or it can be the lead poisoning in the children. They live in the older building, Like in America, when you rent a house, you just want to make sure this house is not old, because they used to use lead in the painting, right? So the child, as you know, they like to pick up in the paint and get the paint and eat it, right? Right. So when they eat it, they get exposed to the lead. So if this happen, right, what's going to happen if it's a very old building? You have been exposed to the lead, and that will affect the children, especially the children, badly regarding the blood diseases and the anemias. Pesticides exposures between farmer, right, as we have the air pollution in the urban area. Localized pattern of the disease. So I'm talking about what? Local, in particular area, in one state, right? Look at the, for example, the dengue fever and how the vector, it's more about Texas, Mexico border. So an area. Why? Because they have the vector live there, with they carry the virus, and causing the dengue fever. So it can be very localized. Time, as I said before, time is very important. Is it secular trend, cyclic trend, point endemic, or clustering? So basically, let's look at the secular first. So secular, it's a gradual change of frequency of the disease of long time. Okay, so if you look at that age adjusted prevalence in the hypertension. Okay, I want to see the figure. Look, there's no figure here. I don't know. Okay, so basically it's secular. I'm looking to the age prevalence to that hypertension. Okay, it's not gradually a change, no secular, because as how the hypertension hit, right? It's a disease, just you having hypertension, yes or no. There is no gradually process of the time to develop hypertension. Cyclic trend, you're gonna have a cycle, increase and decrease in frequency, up and down, up and down, up and down. Okay, as you have in the influenza, when you talk about the diagram in the influenza, how increase the mortality, for example, then drop, then increase, then drop, then increase. It's what we call a cyclic trend. I have a cycle of up and down, as you can see in the diagram here. Point endemic. It's basically about particular group, a response of the group in a place as a source of infection. What does that mean? Outbreak happen. You are going to a barbecue with your friend to the park, and the friend that he prepared the chicken, right? He didn't have the right hygiene, or he gets the chicken, he left it out the refrigerator for a long time. Then he say, oh, let's have the chicken and barbecue, right? What's going to happen? Get infected. Reheated rice, for example. You keep reheating the rice, then having the barbecue, then having the outbreak. Okay, at one point, and the response of that group to that particular event. Cluster. This is a series of events of the same health issue. So having outbreak is not one time, it's a cluster, and it happened in Texas, it happened in here and here at the same time, and with done here in Texas, then it comes in Pennsylvania, then in Carolina. Okay, and this can be also outbreaks included. For example, they have particular type of vegetable, and it came from the same distribution, distributed in Texas first, it happened this and in Pennsylvania, and you find it's in kind of a series of events. Okay. The same thing here regarding the occurrence. The only thing about the occurrence, if this has happened, that cluster is different regarding the geographical regions. It just based on geographical or based on the time, is temporal cluster. Is that related to the time? If it's happened in Texas, it does happen at the same time in Pennsylvania, or there's a difference in the time, or it happened only in Texas and North Carolina, but not Pennsylvania. So all these factors to talk about the clusters. To learn out of this, I know today lecture it was big, and we take it all together in one shot, I know. But let me highlight a few things here for you to take home. Causality, very important. Evaluate causality through the health criteria, very important. Okay. Considering different multi-factor in causality, multivariate causality, not only one cause, very important. To know confidence interval and p-value, very important to estimate the relationship. This is for the new class or new advanced epidemiology. To do a comment in the disease, very important. When you comment in the disease, what's the comments you want to give? That slide, very important to understand it. The most critical slide 1, 2, 3.